Hey guys, welcome back to another episode of Chiropractic Crack and Coffee. I'm Dr. Todd Lloyd in my home studio in Sonoma, California, and I've got my coffee. I'm a chiropractor, and we're going to watch some cracking. Actually, today I want to delve into the topic of frozen shoulder, because if you've ever had frozen shoulder, if you're a clinician who's ever treated frozen shoulder, then you know that it can be a really difficult thing to treat. So before I want to watch some people get treated for frozen shoulder, I want to be able to distinguish between frozen shoulder and pseudo-frozen shoulder. It kind of acts like it's a frozen shoulder, which is really adhesive capsulitis, but it's actually something else. So I'm going to watch physio tutors first, because I think they have a really sensible approach to diagnosis and treatment for a number of orthopedic conditions.
Hoffman et al. From the year 2015 did a study on the amount of active muscle guarding in patients suspected to have frozen shoulder and found that all patients experienced a huge increase in passive abduction while under anesthesia. This means that the loss of range of motion in frozen shoulder can not only be explained by a true capsular contraction alone, but that active stiffness or muscle guarding can play a huge role as well.
So I think this is going to be a theme for this topic. When you have a frozen shoulder, it's not actual adhesions necessarily in the joint capsule that is restricting shoulder range of motion, but it's muscle guarding. And when we watch some of these videos of frozen shoulder treatment, we're going to see that same kind of theme go into play, where they're going to treat the muscles that influence shoulder movement to help with frozen shoulder.
Great test to determine the presence of true frozen shoulder is the Coracoid pain test. It is described to have a sensitivity of 96% and a specificity of 87 to 89% according to Carbone et al. In the year 2010. To perform this test, manually palpate the AC joint, the anterolateral subacromial area, and the coracoid process with your first digit, and record the patient's pain on a VAS scale after every palpation. The test is considered positive for true frozen shoulders when pain on the coracoid region was greater than 30 millimeters on the VAS scale with respect to the acromioclavicular joint and the anterolateral subacromial area. The clinical reason behind this test is that characteristic findings on MRI for frozen shoulder are a thickening of the coracohumeral ligament, the rotator cuff interval, and the coracoid triangle, which are sensitive upon pressure.
So when you have a true frozen shoulder, an MRI is going to show you that the coracohumeral ligament has been thickened under this process. So doing the coracoid pressure test using your digit into the coracoid process. Coracoid process is part of the shoulder blade, but it's in front. That, causing pain, will be a sensitive test to tell you if you've got frozen shoulder or not. That's going to be a sensitive area anyway, probably from general shoulder degeneration, like non-specific shoulder degeneration that can cause shoulder pain and restriction of motion. People have thickening of the shoulder ligaments over time anyway, such as the ligaments or the tendons of the rotator cuff. Let's check out the next video here.
In this video, I'm going to show you how to diagnose frozen shoulder. Frozen shoulder has a prevalence of 2 to 5.3% in the general population, with a peak at 55 years of age and a higher prevalence amongst women, patients with diabetes and thyroid dysfunction, and a previous episode of frozen shoulder on the contralateral side. The pathoanatomical features of frozen shoulder are angiogenesis into the capsule tissue, which produces collagen fiber proliferation, granulation, and contracture of the capsular ligamentous complex. According to Fastamäki et al. In the year 2012, 94% of the cases resolve within 4 to 36 months and 15 months on average. However, Wong et al. In the year 2006
4 to 36 months.
described that complete resolution is unfounded, which is why interventions to regain complete shoulder function might be necessary. The stiff and painful shoulder is identified by a significant and equal loss of both active and passive shoulder movements, but has minimal pain on resisted testing. You can do this by fixating the scapula with your body and a coracoid process on the anterior side with your upper arm. Afterwards, range of motion has to be reduced in at least 2 other planes by at least 25% compared to the other side. For this reason, it makes sense to test pure range of motion in the glenohumeral joint in abduction, and you can do this by fixating the clavicle and scapula, followed by the assessment of flexion, and again with the fixation of the clavicle and scapula.
Okay, so PhysioTutors does an excellent job of showing us what to do to diagnose a frozen shoulder. Coracoid pain test, active range of motion, it's got to be reduced at least 25% in 3 different planes of motion, starting with the shoulder in the 0 position, checking external rotation. And they also mentioned that active muscle guarding is a big factor in frozen shoulder. So we're going to look at some of the treatment with chiropractic. This first one is labeled Intense Screaming Frozen Shoulder Healed in Minutes. This is a long video. We're going to skip past through some of the parts.
So we have Dana here today. He's a personal trainer here in New York City, has a big dance background. You still teach too.
Still teach, yes.
Yeah. You told me your left shoulder's the big thing. Tell me a little bit about it.
Can't raise it up, can't go back. Sleeping is like kind of impossible on this side. So
How long has it been weird?
I'd say a good year and a half.
Okay.
It's just getting worse.
Have you ever got a formal diagnosis on it or MRIs or anything? So turn this way towards the camera, and I'll just stand this way. And take this arm up as high as you can go. This is the good side. And he's got great extension. You know, you can go all the way back.
Mm-hmm.
You did a lot of gymnastics stuff.
Yes, I was on the gymnastics team too.
Were you?
Yes.
Here, move a little closer this way so she's not stuck
Right.
in the corner. Now take this side up. And right away you're recruiting already. So what that means is by the time he gets to here, he's like cheating. He doesn't mean to cheat, it's subconscious. But the body's thinking, the goal is get the frickin'.
So what the doctor should do is probably anchor down the shoulder blade and retest that range of motion to see how much true range of motion he's got in the glenohumeral joint.
Right? So the body just helps with any way it can to get the arm up higher. But if we had you do
So he's got more assessment.
Ever. Now this one
Stuck.
And what I mean by that is like all this starts doing weird shit. Like
So there's that muscle guarding the PhysioTutors we're talking about.
It's constantly trying to figure it out.
Yeah, it might not be adhesive capsulitis. It might be just the frozen shoulder because of muscle involvement.
And it locks up.
Okay, so let's play with that for a second. So this is the bad one.
Mm-hmm.
And hold your arm out to the side and make it firm. Good, he's strong as hell. Tilt your head this way. Hold your arm out to the side. And the arm goes weak.
So pain is going to cause weakness in the associated muscles of the area. So as he's bending his neck to the left and he's testing the right arm for strength, tilting the neck to the left is going to make things weak. It's also going to sort of unstabilize the whole core. The neck needs to be in a neutral position for maximum strength. If you put your neck into a side bend, then it's going to cause weakness in the other muscles of the body. In the arms, I mean. So you can't have a really strong shoulder with your neck bent all the way to the side. It's going to make it weak. You need to have stability up here to do that.
Back like this, hold, and the arm just goes weak. So we see it's compromised, right? Turn around this way.
So it's instability plus that pain response because he's kind of jamming his facets together as he's bending to the side.
Ideas, but I have to, I never worked with you before. Lift your arm up as high as you can. And is there any spots under here that you ever feel?
Yeah, all of it.
Yeah,
Whoa,
so
there.
drop down. Drop that arm down, okay. All right, so slowly, this is what I'm gonna want you to do. Just kind of come up.
This way?
Yeah, and I have to kind of, can I grab you? I'm allowed to work on you?
Whatever what you gotta do.
All right, so this one's a nasty spot for us. Now lift that arm up and put it down.
That's where it's coming from.
That looks like he's working on the serratus anterior.
And put it down. Oh my God. That should kill. Oh, it should feel like a bayonet's in your body.
Dying right now.
And you're a tough bastard, so if this hurts you, lift that arm up. There's more spots. This is just one of them.
So that's,
And then put it down.
I think he's going to do like 20 minutes of muscle work here.
Okay, that's a nasty spot to fill that one.
Trapezius, levator scapula.
Now drop your arms.
So after that muscle work, he's got pretty good range of motion again.
It's getting there. It's getting there. Now lie on your back. You need to come down to this end of the
So he's working on different muscles of the body. Here's go neck adjustment.
This is the spot I found before. I'm going to go in deep here.
Oh. Oh. I feel like my knees.
Yeah, that feels good. All right, so we did a neck adjustment. He's going to work on some muscles in the anterior chest.
Okay, now.
What's he going to do now?
Shoot down a little bit this way.
Side lying position.
I know I'm beating you up, but it's good shit, right? It's good shit.
Oh my gosh.
Where there's a sense that we know if the guy's doing good stuff, right?
Yeah, he's working on the rotator cuff muscles like the teres minor and teres major. Yeah, that looks really painful.
Right.
More elbow work.
Down top of the trap here.
Oh, that's a good adjustment.
Good. Moving around. Move to this edge of the table.
That's a horrible table to work on people. The big activator table. It bounces up and down every time I try to do something to somebody.
It's okay. Good.
Amazing.
Good. Now lie on your side.
It's just not a very good table to work with.
And move closer to me.
Gonna do his low back. Let's see how this looks.
Down. Pull this leg up like this.
The table's way too high for side posture. Didn't even really do a good adjustment. Popping his toes.
This is for comic relief. Because after all the shit I did to you, you're like, now he's freaking popping my toes.
Oh my god.
But that's just to make you happy. All right, so pull that arm up again. Let's do both arms together. It's coming there. You need
It
to
still
work.
compensates a little,
Yeah.
but it's so much better.
All right. Come with your.
Kind of weak. That frozen shoulder's tough too. That he's gonna have a little bit of a rebound as time goes on. It's gonna come back down and get tight again. That was a lot of pain to go through too. I'd rather do some shockwave therapy to some of those areas, especially with such a chronic problem like this. Let's go to the next video. This guy's going to do some specific chiropractic adjustments.
Go like this.
Yeah, that guy's got bigger problems.
Yeah, raise it up slowly.
It hurts.
Understood. He has a lot of trouble lifting this right shoulder ever since he fell in the snow. So this is what we call adhesive capsulitis or frozen shoulder.
Alright, champ. We're gonna start off looking for abnormal temperature, and we see very good.
That device is called a Nervoscope, and what he's looking for is differences in skin temperature. And the theory with this is that if you've got nerve irritation, that's going to cause vasodilation of the blood vessels on the surface of the skin, bringing more heat to the area. So it's a tool that they use to measure for spinal irritation, whether it's nerve irritation or irritation of the soft tissue areas. Maybe if you've got a painful area, that's also going to cause vasodilation. Kind of an antiquated technique, but it's a part of the Gonstead technique. When I was in chiropractic college, I had one of these, and I left my bag containing all my doctor gear in my car as I was going somewhere in the parking lot. Window got smashed. They stole all my stuff, including my laptop and my Nervoscope. I never replaced the Nervoscope. I replaced everything else. So it's an interesting throwback to old-time chiropractic. He's using a skin marker to mark the areas where there's a swing in the needle, showing where the heat is. Now he's palpating soft tissue to see if there's any areas of edema, local areas of swelling in the spine where there could be some irritation. So he's checking the whole spine, doing a whole spine. He's going to clear out the whole spine to clear out the frozen shoulder stuff too.
So when we start to feel a whole entire band right across from that fifth lumbar and the sacrum itself, it may indicate a base posterior sacrum. So we're going to double check on the film to confirm that.
This guy is a true Gonstead guy because he took x-rays too. Then he's palpating. He's motion palpating. He's got the Nervoscope. He's inspecting the skin. And so I like how thorough he is. Every time you rub your fingers up and down someone's spine like that, you can check for a red response. So usually you'll have a red response when you touch somebody's skin. But if there's irritation there, it's going to remain after you pull away. So he's provoking a little bit of irritation in the areas of the skin, going over it over and over. And that's how he's going to find out the true areas of irritation, which can cause pain or muscle imbalance or neurological imbalance. So he's doing a very thorough job with this guy. I would say the full spine x-rays are also a throwback to old-time chiropractic. I don't think they're going to give you too much information compared to spot views of where there's actual pain. It's used as a screening test to show where there are areas of degeneration in the spine. You can see on he's got degenerated lumbar segments. I can see from here. Can't really see the neck too well. When it comes to x-rays, I like to see motion views or stress views. You take an x-ray neutral, you go an x-ray to the side, you go x-ray to the other side. That's going to show how the bones are moving. When you have a static view like this, especially with a full spine view, there are certain levels, there's some degree of distortion with the parallax effect of the x-ray beam diverging from the x-ray tube. So I would rather have a spot view. And I don't know if x-ray is even indicated for this guy because he's coming with a shoulder problem. Maybe fresh after an injury you want to take an x-ray to scout out for fractures. Let's move on. He's explaining what he's doing. We're going to go to the first adjustment. It looks like he's got the patient on a knee chest table, adjusting his lumbar spine.
Until we feel this thing loosen up.
He's adjusting the sacrum. He's pumping it before he adjusts it. This right here is your classic Gonstead set of tables, the Gonstead bench with a felt covering. And this is the knee chest table that he was just using. Knees go right here. Your face goes into the face cradle with a piece of paper. And you can adjust different areas of the spine with that pretty easily. It can be a really painful adjustment if you don't know what you're doing. I think this guy probably knows what he's doing though.
I can work better with a knee. Before time I used to drag like this.
The other part of this Gonstead set is this chair that you sit on. All right, you adjust, you retest. He's watching his gait. He's seeing if his gait has pain-free range of motion again. This high-low table right here is the other part of the Gonstead set used for certain patients. But usually the starter set for a Gonstead clinic is the pelvic bench, the knee chest table, and the cervical chair.
That's good. Sideways, but this way. Try again.
So he adjusted his sacrum, and he's already got improved shoulder range of motion. Now he's inspecting the x-rays again. He's going to go into the thoracic spine. This is more like a soft tissue technique for the scapula. He's going to do the anterior glenohumeral joint. Checking the way the clavicle moves. That's the AC joint, acromioclavicular.
Okay, now it actually was a 7.
Interesting technique. He adjusted the superior AC joint. There's the humerus. Doing a prone neck adjustment. Oh, that's really impressive.
Much better. Yeah. Yes. Much
Try to
better.
go as high as you can.
Ah, so much better.
And try the forward one again.
So I would say that's probably pseudo-frozen shoulder. It's not really the frozen, the adhesive capsulitis. That's really impressive how we got the shoulder range of motion back. And I think it underscores the necessity to do a very thorough job of checking what areas of the spine are irritated and correcting those. So the whole idea with the Gonstead technique is to find it, fix it, and leave it alone. You find it, you accept it where you find it. In this case, he's going to recheck it, and you leave it alone. Because once you remove the irritation in the painful areas of the spine, the neck, the mid-back, that's going to allow the body to heal itself with more efficiency. So that's really impressive. Now the next video is going to be from this group called Trigenics, Frozen Shoulder Clinic. And what we're going to see here is they have this proprietary technique of healing frozen shoulder. And from what I gather by watching their videos is that they use other sorts of soft tissue into the muscles that influence the shoulder joint. So here we have a man who has a problem in the right side. Trouble abducting the shoulder. Apley's test, can't do it. External rotation is messed up. This doctor has an amazing head of hair. They've got some kind of an injection technique. But they're not going to show you what they do because it's their proprietary technique. Which is the O procedure. So he's lost his proprioception to find out where his other hand is because of all the work they did. He must have had this frozen shoulder for a long time.
He's lost his hand. It's been so. Oh, must be somewhere. Oh, there it is. All right.
Whatever they did to this guy must have been really intense because he can't even find out where his hand is. He probably barely feel his arm. Using vibration therapy on the muscles.
Don't do it too fast. Don't want to be a hero here. Go ahead.
Checking the strength of his shoulder.
Exercise you have to do every hour on the hour.
So he's going to have him exercise the range of motion of the shoulder once an hour, every hour. Looks like he's still got fear avoidance behavior, and he's still lost some of that proprioceptive feedback from his joint position sense. Making kind of slow to bring that shoulder up.
So this is now less than 24 hours later. It's the okay.
There are points where it gets more
catches a little bit. Yeah. Those are the points. Those are the points where it was caught before.
So there we go. That's our assessment of frozen shoulder techniques. In my clinic, in the past, I've really struggled with frozen shoulder patients. It's a really slow process usually. I think with these techniques of using soft tissue therapy on some of the muscles surrounding the shoulder can really help to accelerate that. I'm really impressed with the Gonstead chiropractor who got that guy's shoulder moving really well almost immediately. And I think he did probably the best job, except for this Trigenics video. They did some kind of injection in there. You don't really know exactly what they're doing because it's so proprietary. The guy in the Trigenics video looks like he has had the frozen shoulder for a long time. like a longer period of time. While the guy being treated by the Gonstead chiropractor had that more recently, like a more recent injury. So there you have it. That's my assessment of frozen shoulder techniques. I'm Dr. Todd Lloyd, coming to you from my home studio in Sonoma, California. I'll see you at the next one.